All right, so this is a case of adult retinopathy of retinopathy of prematurity. We talked about this earlier today. This is a 69-year-old patient referred to me prior to cataract surgery by her cataract surgeon. Just they found some abnormal peripheral RPE changes, some vitreous changes. Wanted to make sure she was cleared before cataract surgery. She had pretty good vision, 20/30, and really, the first time we elicited this history of prematurity was when she came to see us. I had the courtesy of having the Optos images before I went in to see her, and that really helped, having seen this a few times. Basically, this patient was born at 2 pounds and 10 ounces 69 years ago. She was given supplemental oxygen. She was in the pre-screening era, born in Germany actually at the time, and had been relatively unscathed with no issues whatsoever. Now, when we think about adult ROP, we have to break it down into two real generations of patients. There's the boomer ROP, and these are patients born between the 40s and the 80s. And at that time, we really didn't know that cryotherapy or laser ablation was needed for certain stages of ROP. They were born with higher birth rates, oftentimes exposed to oxygen and higher concentrations of oxygen than we utilize now. Then there's the ablation generation, and in these patients, they're typically going to be lower birth weight, more immature retina, but more treated retinas. So you might actually see these patients come in with 360 degrees of peripheral PRP laser or cryotherapy. Here's this patient's eyes, and we can see a couple of characteristic things. First of all, the right eye seems to be less advanced than the left eye. We can see vitreous opacities. You can see what looks like relatively normal retinal vasculature posteriorly, but as we look, we'll see those vessels temporally really start to straighten out. We can see this patient has developed full, mature retinal vascularization. And then just posterior to the equator, we can see the vitreous bands, this ridge-like vitreous band. When we look at the left eye, we can see that cicatricial ridge. We can see RPE changes anterior to it, and the chorioretinal scarring, likely from traction to that retina, where that retina is healed and created a chorioretinal scar. In the left eye, here's where we can see on the left-hand side of this image the vitreous ridge, and you can see peripheral cobblestone. In the right eye, we can see the same process, less advanced. We can see straightening of those retinal vessels. And then once again, towards the left-hand side of the image, you can see that cicatricial ridge of vitreous opacity. Now, in many of these cases, you can see a foveal aplasia, where it's just a straight line across, no foveal dip. In this patient, you actually do have a fairly normal-looking foveal contour and a normal-looking OCT, which is great and really good news for this patient. So we can see here this patient has adult retinopathy of prematurity. They were born premature. It was never diagnosed. Fortunately, they developed normal or developed retinal vascularization all the way out to the periphery, and now have presented at 69 years old with a visually significant cataract prior to cataract clearance. What's very interesting about these patients with adult untreated ROP, higher rate of retinal detachment, a lot more lattice degeneration, and we can see a third of these patients have that ridge-like vitreous condensation, and you can actually have tractional retinoschisis. You can see these higher rates of retinal tears, detachment, lattice degeneration, and whatnot. These are patients that really need to be observed over a lifetime. And if they do detach, unfortunately, they have tougher outcomes, worse outcomes than our traditional retinal detachment patients, with 16% of these patients requiring retained silicone oil after their final operation. And basically, when we have to leave silicone oil in an eye, it's bad news. It means that we're worried that that patient's going to redetach, or that patient has ocular hypotony. So tough to treat these patients. And if they have a lot of lattice degeneration, there's some thought behind doing prophylactic laser treatment peripherally. In addition, from an anterior segment standpoint, these patients can have shorter axial lengths, steeper corneal radiuses, thicker lenses, and higher corneal aberrations. So in our patient, we had several options. We could clear the patient and observe her. We could do laser first. We could clear, then do laser. We just decided to observe her, and we're going to see her back after she's had her cataract surgery. Once again, cataract surgery increases the risk of retinal tears and detachments slightly, and adult ROP increases the risk of retinal tears and detachments. So we want to just keep a watch on her, and if we see anything that looks concerning, obviously consider laser treatment at that point. So just a few teaching points. Ask about that birth history if you see a patient with similar findings. Good central acuity does not exclude severe peripheral disease, as in our patient we could see not really severe peripheral disease, but peripheral changes. Risk marker is anterior, not posterior. The avascular retina really is on the anterior edge of the retina, not more posteriorly. Pre-cataract clearance, from a retinal standpoint, we're looking for any areas of traction, lattice degeneration, anything that might need to be treated. And here's some of the references.